Hello everybody, now we are going to start electrical activity of the heart. First, we are going to discuss action potential and then ECG. So now let's start with action potential of the heart. So if you look at this diagram in front of you, so this diagram is taken from a book and you can easily find out that the action potential of the heart has two distinct types. That is, here it is written action potential of the myocardium cell, which is clearly distinct from action potential of the pacemaker cell. So we are first going to discuss what is the difference between these two types of action potential, and then we will be discussing the ionic basis of action potential. So cardiac action potential, I am writing here the action potential of the heart, okay, are mainly of two types. If I divide this, so this is mainly of two types. One is fast type action potential and second one is the slow type action potential. Slow type action potential, right? So please be careful here because the question has already been asked that fast type action potential is seen in which type of tissue. So your answer will be myocardium, that means the atrium and ventricular muscles, they have this first kind of action potential, and second one is the Purkinje fiber, right? These two tissue have the fast type action potential. Now if you look at the slow type action potential, it is typically seen in case of nodal tissue, that means it is seen in case of SA node, okay, as well as the AV node typically. Bundle of His also this slow type of action potential is seen there, but typically it is SA node and AV node, right? So why it is known as fast type and why it is known as slow type, you will be understanding. Just hold on. But before discussing other things, let's try to understand what is the resting membrane potential of this myocardium. We have discussed this in previous session. So this is minus 90 millivolt like that of the skeletal muscle RMP. But if you look at the Purkinje fiber, Guyton is saying it is little different, that is minus 80 millivolt is the RMP of the Purkinje fiber. Similarly, if you look at the SA node, the RMP resting membrane potential is minus 50 millivolt and AV node is more negative, that is minus 60 millivolt. But if you look different book, they are saying that the SA node and AV node, their RMP, okay, it is not a fixed value. The RMP moves from minus 65 millivolt to minus 40 millivolt. So actually your ideal answer should be that the nodal tissue, that is the SA node and AV node, RMP of these two tissue ranges from minus 65 to minus 40 millivolt. It's not a fixed value, but sometimes in our exam system they ask you to give an exact value of SA nodal RMP, AV nodal RMP. In that cases, you are going to mark minus 50 millivolt for SA node, minus 60 millivolt for AV node, but actually it is a range, right? So first of all, you are finding out that the fast type and slow type action potential is seen in different tissue and RMP of those different tissue is also different. Now if I draw the fast type action potential, so I'm drawing the fast type action potential here, right? You have seen this diagram multiple times in books because this is the basis of cardiac arrhythmia. So in pharmacology, you will also see this kind of picture. Okay, so this is typical of first type action potential. So here the flat portion, this straight line, this is nothing but the resting membrane potential of the cell. So resting membrane potential means all of you know that this is x-axis of this graph is the time axis and y-axis of this graph is the membrane voltage axis. So this RMP is minus 90 millivolt if it is a myocardium, right? So from this minus 90 millivolt, when the RMP is moving to plus 35 millivolt, this phase is known as the phase number 0 of action potential, right? Then there is a small phase which is returning back towards the RMP. You can find out here where I am marking. So this part where the RMP is returning, where the resting membrane voltage is returning towards the RMP, this is known as the phase number 1. Then you can find out a long plateau portion. This part is known as the phase number 2, and then one part of the action potential is returning back to resting membrane voltage. This is phase number 3, and resting membrane potential is known as phase number 4. So I can easily find out that in case of fast type action potential, there are 5 distinct phases. Okay, so I can easily understand that phases in case of fast type action potential is start from 0 to phase number 4, means total 5 phases are there. But if you look at the slow type action potential, here I am drawing the slow type action potential. So again, there will be an x-axis, okay, that is the time axis, and there will be an y-axis, that is the membrane potential axis. Here, if I draw the slow type action potential, okay, look at it, is very distinct. There is a phase where membrane voltage is gradually rising, and then suddenly there is jump of membrane voltage, although it's a bit slower, and then the membrane voltage again returning back to the original voltage, that is the resting membrane voltage. So if you find out here, then the membrane voltage where from it is starting is minus 65 millivolt, and then this part where the action potential is starting, this is minus 40 millivolt, and then the membrane voltage is rising up to plus 10 millivolt, and again it is returning back to minus 65 millivolt, right? So I can easily find out here that there is no straight line, there is no flat portion line, there is no resting membrane voltage like that of the fast type action potential, but rather here the resting membrane voltage is not stable, but the resting membrane voltage is fluctuating from minus 65 to minus 40, again it is returning back to minus 65, and whenever it is returned back to minus 65, again it will, okay, again it will rise up to minus 40 millivolt like this, right? So this unstable membrane voltage, it is like that of the resting membrane voltage. Listen carefully. So this part, if I mark here, this is like the resting membrane voltage, but it is not a stable one. It's an unstable resting membrane voltage in case of nodal tissue. This unstable resting membrane voltage in case of nodal tissue is also known as pacemaker potential. This is also known as pacemaker potential, or this is more commonly known as pre-potential. Very important for MCQ. This is commonly known as pre-potential, or it is also known as diastolic depolarization phase. Diastolic depolarization phase of action potential. No doubt that this part where I have written that it is the RMP, okay, this RMP is unstable, it is moving from minus 65 to minus 40 millivolt, right? So if I correlate this RMP phase with that of the previous one, so RMP here is phase number 4. So that's why this RMP phase of the nodal tissue also, this is also known as the phase number 4. Phase number 4 or resting membrane voltage, but this resting membrane voltage is commonly known as pre-potential phase or pacemaker potential phase or diastolic depolarization phase, right? Now whenever this resting membrane potential is touching this minus 40 millivolt, minus 40 millivolt is the threshold voltage for nodal tissue. Threshold voltage for nodal tissue. You know the meaning of threshold voltage from the previous discussion. So whenever it is touching the threshold voltage, the action potential will start. The action potential will start, and this part is known as the phase number 0 of nodal tissue action potential. Phase number 0 of nodal tissue action potential. But if you look at this phase number 0 here, it is rising maximally up to which membrane voltage? Plus 10 millivolt. But in the previous one, if you look at the first type action potential, here the membrane voltage is rising up to plus 35 millivolts. So this is another difference. Now if you look at the phase number 0 of nodal tissue action potential, look at the slope of the phase number 0, slope. So it is rising in upward direction, but this rising in upward direction is slowly rising, right? Why slowly? Because the channel which is responsible for it, I'll tell you later, that is slow in nature. The channel is slow in nature. But if you look at the phase number 0 of fast type action potential, it is rising upward with a very steeper slope, with a very high speed. That's why, because of the slope of the phase number 0, because of the slope of phase number 0 is very rapid, in case of fast type action potential, the action potential is known as fast type. But if you look at the phase number 0 slope, phase 0 slope, in case of nodal tissue action potential, then it is slowly rising upward. That's why this is known as slow type action potential, slow type action potential. So this fast and slow division is based on the slope of the phase number 0. Now then, when the phase number 0 is over, then the membrane voltage is returning towards the resting membrane voltage. When the membrane voltage completely returns towards the membrane voltage, okay, resting membrane voltage, that will be known as the phase number 3. So I can easily understand that in case of nodal tissue action potential, phase number 1 as well as phase number 2 is not seen. Please note down, in case of nodal tissue action potential, phase number 1 and phase number 2 is not seen. Phase number 1 is never seen in the nodal tissue because the channel which is responsible for phase number 1 in case of fast type action potential, that channel is not present in case of nodal tissue, so it is never ever present. Phase number 2, sometimes it may be present in case of nodal tissue, but typically it is absent. Right? So these are the basic difference between the fast type action potential and slow type action potential. I hope all of you understand this part, right? Okay, all of you understand this, right? Okay, so difference is not only the membrane voltage, the shape of action potential, as well as their ionic bases are also different. So now we are going to discuss the ionic basis of fast type action potential. So fast type action potential, where it is seen, typically the myocardium, that is the atrial and ventricular muscle, and second, it is also seen in Purkinje fiber, right? So now again I am drawing the fast type action potential, right? So this is minus 90 millivolt, okay? Then the membrane voltage is rapidly rising from minus 90 to plus 35 millivolt. Then the membrane voltage is returning back a little, that is the phase number 1, and then there is a stable voltage, and then after this stability the membrane voltage completely return to baseline once again. So this is the typical action potential which is found in myocardium and Purkinje fiber. Now to describe the ionic basis, what I am doing, I am drawing a myocardium cell just below this diagram. So this is a typical myocardium cell, right? Okay, so what I am going to do, we are going to discuss phases one after another and what is the ionic basis of those phases, right? So first we are starting from the phase number 0. So this is phase number 0 of action potential, right? So I should write it carefully. So this is phase number 0. So if I ask you, phase number 0 means where the membrane voltage is rising from minus 90 to plus 35 millivolt. This is my phase number 0. So obvious thing is that normally when the resting membrane voltage is minus 90, then interior of the cell is negative and exterior is positive, and if I measure the difference between this, then this is nothing but minus 90. That we know. This concept of RMP we know from the previous discussion, right? So whenever this myocardium cell is stimulated, there will be opening of a very fast type of channel here, and all of you know the name of this channel. So there will be opening of a voltage gated sodium channel whenever the myocardium is stimulated. And due to opening of this voltage gated sodium channel, huge number of sodium will enter into the myocardium cell rapidly because the channel is very fast in nature. And whenever huge amount of sodium is entering in the myocardium, the membrane voltage, okay, the interior of the cell membrane voltage will rapidly rise up to plus 35 millivolt, and that is giving rise to phase number 0 of myocardium action potential. So all of you know this thing. Still I am writing here So action potential phase number 0. This phase is known as the depolarizing phase of action potential. So depolarizing phase of action potential is due to entry of sodium. Entry of sodium. Always try to remember the channel name. So this is very fast voltage gated sodium channel. Voltage gated sodium channel, right? Please note down this complete name. In previous session during skeletal muscle discussion, I told you that this voltage gated sodium channel, in short it is written Na plus dot V or NAV, right? Voltage gated sodium channel. And I also told you that it has different sub variety starting from 1.1 up to 1.9, means total 9 different sub variety of voltage gated sodium channel are there. You have to remember that in case of myocardium, the typical voltage gated sodium channel which is present is NAV 1.5, right? So for skeletal muscle that is 1.4, and in case of myocardium this is NAV 1.5. Very crucial information. Also remember, this channel is very fast. What do you mean by very fast channel? Means opening of the channel is very fast. It requires only 0.1 millisecond, and after opening it will be inactivated after 1 millisecond. So it will remain open for only 1 millisecond and then it will be inactivated after 1 millisecond. So opening time to open the channel is 0.1 millisecond and then it will be inactivated after 1 millisecond. That is the meaning of the first channel. Okay, now next phase is the phase number 1. So this part is the phase number 1 where the membrane voltage is returning towards the RMP, but it is not complete return. It is partially returning towards the RMP. So whenever the membrane voltage again coming back towards the RMP, we know that is known as the repolarization. But in case of phase number 1, I can easily find out that the repolarization is not complete, right? That's why the name of this phase number 1 is known as initial rapid repolarization. So phase number 1 is known as initial, okay, rapid repolarization phase, repolarization phase. And this phase is very transient, very transient, very short time duration, right? So this is phase number 1, initial rapid repolarization. Now during phase number 1, what is the ionic basis? This is very important for MCQ. Multiple times it has been asked. First of all, the important thing is that there will be exit of potassium from the cell. So potassium efflux from the cell. Parallelly, there will be inactivation of the previously open voltage gated sodium channel, because I told you this voltage gated sodium channel is very fast in nature, opening and inactivation. So that's why inactivation of the voltage gated sodium channel is also there and exit of potassium is also there. But the main factor, if you have to choose between them, then main factor is exit of potassium, because if only voltage gated sodium channel is inactivated but without any potassium leak from the cell, then the membrane voltage will be stabilized here. Okay, membrane voltage will be stabilized here. Okay, it is not going to return. It is returning means some ion has to leak from the cell. So in this diagram, okay, I can draw a channel like here. So this channel, okay, is the potassium channel through which potassium is leaking. Because the potassium is leaking from the cell, so cell is losing positive charge, and that's why the membrane voltage is returning towards the RMP. But it is not complete return. Why it is not complete return? You will see later. Okay, just you will see. Okay, so now I have to remember that the exit of potassium is occurring through a potassium channel. What is the name of this potassium channel? This potassium channel is known as KTO type of potassium channel. KTO type of potassium channel. So I am writing here that this exit of potassium occurs through KTO type of channel. T stands for transient, T stands for transient, O stands for outward potassium channel, right? So transient outward potassium channels open up during phase number 1, and through this channel, KTO channel, potassium goes out of the cell, as well as there is inactivation of voltage gated sodium channel. So cell is losing positive charge and the membrane voltage is returning. Very, very crucial, very crucial, right? Now the next phase is phase number 2. So next part, there is a large part of the membrane voltage where the membrane voltage is almost stable. The membrane voltage is almost stable. It is not changing much, and this is known as the phase number 2 of myocardium action potential, which is also known as plateau phase. So I'm writing here phase number 2, right? So this is known as the plateau phase of myocardium action potential, right? So you also have to note down the name of these phases, like depolarizing phases, initial rapid repolarization, and this is the plateau phase. So if I want to understand that why there is plateau, okay, so you look at this diagram. So already your potassium channel is open, that is a KTO type of potassium channel, okay, as well as there will be opening up of further potassium channel, and that is different variety. I will tell you the name. So I'm writing here that more potassium channels also open up, but these potassium channels are not the KTO. KTO is already open, right? But a different kind of potassium channel open up through which more potassium goes out. So question is, if more potassium is going out, then the membrane voltage should repolarize, but that is not happening, because in addition to this potassium channel, there is also opening of another channel in between, and that is nothing but calcium channel. So look at here. So in between, there is also opening of calcium channel through which calcium will enter in the cell. Calcium will enter in the cell. Calcium will enter in the cell. So now you look at, so whatever charges the cell is losing in terms of potassium, same amount of positive charge the cell is also gaining. So whenever it is losing positive charge, equal amount of positive gain is also occurring in the cell. That's why what will happen, the membrane voltage is not going to change. It will be stabilized at a particular voltage, and that is known as the plateau phase. So if I write down the ionic basis of this plateau phase, so your answer will be proportionally 2 channels are open, okay? So potassium channels, okay, that is also open, as well as the calcium channel that is also open, right? So because of this 2 channel opening, potassium exit is going on and calcium entry is also going on simultaneously, and both of them are equal positive charge. So what is happening, the membrane voltage is stabilized. So I told you that in phase 2 the KTO channel is still open, although the name of this channel is transient. But please remember that even at the initial part of the phase 2, the KTO channel remain open, but there will be opening up of a separate type of potassium channel that is known as potassium channel, which is delayed rectifier potassium channel. Delayed rectifier type of potassium channel. This delayed rectifier potassium channel also has 2 types. One is rapid type of delayed rectifier potassium channel, and one is slow type of delayed rectifier potassium channel. So what I'm saying, you may be a little confused, but no confusion here. Look at this diagram. So phase number 2, if you look at phase number 2, I told you that KTO channel is already open in the initial part of the phase number 2. Apart from that, there will be opening of the delayed rectifier type of potassium channel, KR. KR stands for rectifier type of potassium channel. This rectifier channel of potassium channel also has 2 variety, that is the rapid variety as well as the slow variety. The rapid variety will open up in the beginning of the phase 2, and the slow variety of the potassium channel will open up in the later half of the phase 2. That is the meaning that during phase number 2, 3 different types of potassium channels are open. That is a KTO, okay, rapid variety of delayed rectifier potassium channel, and slow variety of delayed rectifier potassium channel. Please note down, that is the potassium channel variety. Now for calcium, if I ask you which type of calcium is open during the phase number 2, your answer, this is L type voltage gated L type voltage gated calcium channel, which is also known as DHPR type of channel, dihydropyridine receptor channel. And all of you know from your pharmacology knowledge that this is the channel which is blocked by verapamils and similar groups of drugs. This similar kind of channel, that is the L-type voltage gated channel, is also present in vascular smooth muscles which are blocked by nifedipine, amlodipine type of drugs, right? So this DHPR channel is the calcium channel through which calcium is entering in the cell. In the skeletal muscle chapter, I told you that there is a recent naming of this channel like that of the voltage gated sodium channel, and this is known as CAV 1.2 types of channel. I told you that CAV 1.1 is present in case of skeletal muscle and CAV 1.2 is present in case of cardiac muscle. So please remember, this DHPR channel is a voltage gated calcium channel which is a slow variety. This channel is also known as CAV 1.2 types of channel. So now we know the name of the potassium channel in phase number 2, that is the KTO and delayed rectifier potassium channel, and we know the name of the voltage gated calcium channel, that is the DHPR channel or CAV 1.2 types of channel, right? So this is about the phase number 2. Now let's see. So you have to remember one thing, that the calcium which is entering in this phase number 2, this will initiate the contraction of the cardiac muscle. This will initiate the contraction of the cardiac muscle. Means contraction will not start with the phase number 0, because phase number 0 there is entry of sodium only. Sodium cannot cause contraction. Calcium is entering in phase number 2. So contraction will initiate when the calcium is entering in phase number 2, right? Now when both of these channels are open, calcium channel or potassium channel, we have seen the plateau is occurring, the phase number 2 is occurring. Now between these two channels, whenever the calcium channel is closed up but potassium channel is still open, right? So now you understand that the potassium channel is still open, right? But calcium channel is getting closed. So I should draw with the same color. So potassium channel is still open, right? Although in reduced number, but it is still open, right? Potassium channel is still open. So positive charge is going out of the cell, but calcium channel is closed. So in between, the calcium channel are closed. So what will happen? Now the cell is losing huge amount of positive charge. So gradually the interior of the cell will be negative and the membrane voltage will return back to the resting membrane voltage. This phase is known as the phase number 3 of myocardium action potential. So if I write down phase number 3, this is the complete repolarization phase. So phase number 3 is known as the repolarization phase. So this is the complete repolarization, but we only say repolarization because the phase number 1 is already named as initial rapid repolarization, and here phase number 3 is only repolarization. So repolarization means I can easily write down that the calcium permeability, okay, calcium permeability is lesser than potassium permeability, lesser than potassium permeability, right? Getting my point? So whenever the two channels are open proportionally, the plateau is there. But whenever calcium channel number are decreasing in proportion to potassium channel number, then the phase number 3 will be started. At the end of the phase number 2, obviously there will be closure of all the voltage gated calcium channel, but potassium channel is still open. Potassium channel are still open. Potassium channel are still open, and because of this, the phase number 3 will return to the baseline, right? So initially, only the number of calcium channel will decrease, which is lesser than that of the potassium channel. But gradually, the closure of the calcium channel will be completed, and potassium channel will remain open, and that will bring the phase number 3, right? So this is about the ionic basis of myocardium action potential in different phases. Now we have completed our understanding up to this phase number 3, right? But you have to return the membrane voltage to phase number 4, that is nothing but the resting membrane voltage, right? You have to return the membrane voltage completely to phase number 4, which has been disturbed already. Why it is disturbed? Because during action potential, sodium has entered inside the cell, which is huge in amount. Cell has lost huge amount of potassium, right? And cell has already gained some amount of calcium. So resting membrane voltage means I have to reverse all this ionic composition which has changed inside the cell. How can I do that? Okay, I can do it easily because we have some transporter or carrier protein here. So what is that? So first, the sodium will go out of the cell. The sodium will be thrown out of the cell with the help of a pump, and this pump is nothing but sodium potassium ATPase pump, the universal pump, right? So that will correct this disturbance of sodium and potassium. It will throw sodium out of the cell and it will take back the potassium inside the cell. So sodium and potassium is corrected. Now the calcium. So I require another pump. Okay, I require another transporter protein which can throw calcium out of the cell, but it cannot do alone because the calcium is going against the concentration gradient. So you must have to take back sodium into the cell, which is moving along the concentration gradient. So this transporter, okay, this transporter is known as sodium calcium exchanger, NCX. Okay, we have discussed this in general physiology in detail. Sodium calcium exchanger is written with X, right? And this is my sodium potassium ATPase molecule, right? So whenever the sodium calcium exchanger is working, I can throw the calcium out of the cell easily, but again you have taken the sodium inside the cell. So again you have to remove this sodium from the cell, and that can only be done by the sodium potassium ATPase pump. That means I can easily understand that this sodium calcium exchanger is dependent on the sodium potassium ATPase pump, and I told you clearly in general physiology that this NCX is a secondary active transporter and the sodium potassium ATPase is a primary active transporter. Secondary active transporter, that is the NCX, okay, is dependent on primary active transporter, that is sodium potassium ATPase pump. And because of which, if you give the blocker of this sodium potassium ATPase blocker, all of you know that this is nothing but digoxin, okay, digitalis group of drug. So if you give digoxin or ovabin group of drug, what will happen? The sodium potassium ATPase pump will be inhibited. Whenever you inhibit sodium potassium ATPase pump, because the NCX pump is dependent on it, it will also be inhibited. So this pump will also inhibited. Now if this sodium calcium exchanger is inhibited, what will be the problem? Problem is that you will not be able to throw this calcium out of this cell. So what will happen to the calcium concentration inside the myocardial cell? Calcium concentration will gradually increase, and because of increased calcium concentration, the force of contraction of the myocardium will also increase, and that is the mechanism of action of digoxin drug. I hope all of you know this thing from your pharmacology knowledge. So I can understand that for restoration of the resting membrane voltage, okay, so I'm writing here RMP, that is the phase number 4. So for restoration of this resting membrane voltage, I require this sodium potassium ATPase pump, okay, which is correcting the sodium and potassium, as well as I also require the NCX pump, which is correcting the calcium balance. And I told you repeatedly that this is my primary active transporter and this one is the secondary active transporter. This is an antiporter, the secondary active transporter. So this is about the ionic basis of action potential in case of myocardium cell. Now we'll continue this understanding with little more. Okay, so again come back to this diagram. I told you already that the calcium which is entering in phase number 2, this phase number 2 is very, very crucial because calcium is entering in this phase. That is basically initiating contraction of the myocardial cell. So now we are going to look at this part, that how this contraction is initiated after the action potential, right? So again I am drawing a myocardium cell, right? So this is a myocardium cell once again. So action potential is appearing, and during this phase number 2 the calcium is entering in the cell. What is the name of this channel? DHPR. If you have already read the skeletal muscle chapter, then you will be finding out that this calcium channel, which is we are talking about the DHPR channel or the CAV 1.2 channel, CAV 1.2 channel, this channel is present on the T-tubular membrane, T-tubular membrane. So I am not drawing that, but this channel is mainly present on cell membrane. But which part of the cell membrane? The T-tubules, right? But the calcium which is entering here, obviously this is entering from the extracellular fluid, right? But the amount of this calcium is very, very less. It will not be able to cause full contraction of the myocardium. So you require another source of calcium, and this source is nothing but sarcoplasmic reticulum calcium. I told you that this spherical terminal part of sarcoplasmic reticulum is known as cisterna, and this cisterna is the region where huge amount of calcium is stored. So this is nothing but my sarcoplasmic reticulum. But how to take out this calcium from cisterna to the cytoplasm? Because the contraction means you require calcium in the cytoplasm. Okay, so you have to take out this calcium from the cytoplasm. I hope you know the mechanism. There is presence of a very particular channel here, which is the calcium release channel, right? And this channel is known as ryanodine receptor channel, RYR channel. I told you in skeletal muscle, RYR has three different variety. One, RYR1 is for skeletal muscle, RYR2 is for myocardium, and RYR3 is for smooth muscle. So now you look at the mechanism. So whenever there is an action potential, the extracellular calcium is entering in the myocardium cell. This extracellular calcium is going to stimulate the RYR channel. Whenever the RYR channel is stimulated, further calcium is coming out to the cytoplasm from sarcoplasmic reticulum. If you look at the amount, the extracellular calcium is only 20% of the total calcium, and the sarcoplasmic calcium is 80% of the total calcium. So this extracellular calcium as well as this sarcoplasmic reticulum calcium, combination of these two calcium is now going to cause contraction of the myocardium cell. This is going to cause contraction of the myocardium cell, and this phenomenon by which the ECF calcium is stimulating the release of sarcoplasmic reticulum calcium. I told you the name of this mechanism. This mechanism is known as CICR, that is the calcium induced calcium release. One calcium which is coming from ECF, that is inducing the second calcium release from sarcoplasmic reticulum. That's why this is known as calcium induced calcium release. One calcium is inducing other calcium release. So this is very, very essential phenomena in case of myocardium. And remember, if you block this extracellular calcium from entering in the cell, the intracellular calcium will also not be released. Getting my point? If you block this DHPR channel, if you block this CAV 1.2 channel completely, then outside calcium is not entering. And if the outside calcium is not entering, then RYR channel will also not open up. That means, although that this ECF calcium is very less in amount, ECF calcium only 20%, but it is known as the essential calcium for myocardium contraction, because without this calcium, myocardium contraction will not be initiated, right? So this is the important thing that you have to remember. Okay, you can get experimental question, like for example, suppose you are doing experiment on a mammalian heart, right? So during the perfusion of this mammalian heart, if the extracellular fluid contains 0 calcium, then the contraction of the heart will be stopped. Okay, if your blood calcium is completely 0, then the heart contraction will also stop. That is the applied part of this thing, right? Now I already told that when the contraction is over, you have to cause relaxation of the myocardium. So relaxation of the myocardium means the 20% calcium which has reached from the extracellular fluid, you have to return it to the extracellular fluid only. Okay, so this 20% calcium I have to put it back into the extracellular fluid when the contraction is over. Okay, so what I am discussing? I am discussing the relaxation of myocardium. So the contraction is over. Now we have to relax. So you have to remove this 20% calcium to the extracellular fluid, and that will be done by, already we have discussed this transporter. This is nothing but my NCX, which is throwing calcium out of the cell. But not only that, you have to mop up this 80% calcium from cytoplasm to the sarcoplasmic reticulum, and this mopping up is done by a transporter which is known as SERCA. Again, we have discussed this thing. SERCA means sarcoplasmic endoplasmic reticulum calcium ATPase. So this is a calcium ATPase molecule, primary active transporter, sarcoplasmic as well as endoplasmic reticulum calcium ATPase. So now I can understand that the relaxation require this SERCA pump also, which is mopping up 80% of the calcium. It also requires NCX, which is throwing 20% of the calcium to outside the cell, right? So these are the two transporters which I require for complete relaxation of the myocardium. So again, this SERCA is a primary active transporter. So again, the ATP molecule is required for the relaxation of the myocardium also, right? Now, one extra part. This SERCA pump remain under the inhibition of another protein molecule, and this protein molecule is located here close to this SERCA pump. Okay, the name of this protein molecule is phospholamban. The name of this protein molecule is phospholamban, important for central institute examination. So what is phospholamban? The phospholamban is an inhibitor of SERCA pump, SERCA. So normally when the phospholamban protein is located close to this SERCA pump, so this is my phospholamban protein, right? Located close to the SERCA pump, and it is inhibiting the SERCA pump. If you are inhibiting SERCA pump, what will happen to your relaxation? Relaxation will be slower. Relaxation time will be increased, right? But by certain means, if you causes phosphorylation of this, so I'm writing here phosphorylation of this phospholamban protein, what will happen? It will remove the inhibition. So there will be loss of inhibition of SERCA pump, loss of inhibition of SERCA pump. So if the SERCA pump is lost from its inhibition, so what will happen? I can easily understand that it will mop up the calcium in a very rapid fashion. So if you are mopping the calcium in a very rapid fashion, what will happen? There will be faster relaxation of the myocardium. So I'm writing here, this will lead to faster relaxation of myocardium. Faster relaxation of myocardium, note down, is known as positive lusitropic effect. This is known as positive lusitropic effect on heart. So what I am saying, you must have heard about the positive inotropic effect, positive dromotropic effect, positive chronotropic effect, positive bathmotropic effect. Okay, last two level mein. Okay, so this positive lusitropic effect means this is related to relaxation of the myocardium. If the relaxation is becoming faster, means relaxation time is decreasing. Relaxation faster means relaxation time is decreasing. That is known as positive lusitropic effect. So positive lusitropic means faster relaxation, decrease in total relaxation time, right? How it can be done? It can be done by phosphorylation of phospholamban protein. But question is, who is going to cause this phosphorylation of phospholamban protein, sir? Yes, the phosphorylation can be done by certain kinases, and that kinases can be stimulated by CAMP, cyclic AMP. So by any means, if you can increase the CAMP concentration within the myocardium cell, then the relaxation of the myocardium will be faster. How I'm going to increase a CAMP? This can be done by stimulation of the beta 1 receptor. So if you causes stimulation of this beta 1 receptor, then we know that the beta 1 receptor is a G protein couple receptor. That G protein is going to produce a second messenger, that is the CMP. That CMP will causes phosphorylation of the phospholamban, and that will causes positive lusitropic effect. And who is going to stimulate this beta 1 receptor? Sympathetic system. So if you stimulate sympathetic system, your myocardium relaxation will be faster, and that is positive lucitropy effect, right? So how this is happening? This is happening through phospholamban protein. Now we also know that if you stimulate sympathetic system, it causes positive inotropic effect also, sir, that it increases the force of myocardial contraction. Answer is yes. What is the mechanism? The mechanism is very similar. That is, this CAMP, this is also a stimulator for L-type voltage-gated calcium channel. L-type voltage-gated calcium channel, the DHPH channel that we have discussed earlier, that channel is stimulated by this CAMP. So two things is happening. Whenever you are stimulating the sympathetic system, okay, on myocardium cell, it is stimulating the beta 1 receptor, which is generating huge amount of CMP. CMP on one hand stimulating the L-type voltage-gated calcium channel. Because of this stimulation, what will happen? Huge amount of entry of calcium will occur inside the myocardium from the extracellular fluid, and that will causes increased force of myocardium contraction. Increased force of contraction. This increased force of contraction is known as positive inotropic effect of myocardium. This is known as positive inotropic or inotropic effect on myocardium. And if you look at the second effect of CMP, then it is activating the various kinases enzyme. That kinases is causing phosphorylation of phospholamban protein. That is causing stimulation of sarcopamp. This is actually not stimulation. Basically, this is loss of inhibition of sarcopamp, and because of this, the myocardium is relaxing at a faster rate, that is positive lusitropic effect, right? So in this diagram, this is very crucial diagram. In this diagram, I can imagine this thing like this, that here is your beta 1 receptor, right? So whenever you are stimulating the sympathetic system is releasing, okay, epinephrine and norepinephrine, that is stimulating this beta 1, and then this beta 1 is producing CAMP, right? CMP is rising. This CAMP, what it is doing? It is doing two things. One, it is directly stimulating this DHPR channel, and then second one, it is also stimulating this phospholamban protein. And by this way, the positive inotropic effect is also occurring, as well as positive lusitropic effect is also occurring. You must be thinking that, sir, sympathetic system, if you stimulate, there is increased heart rate also, positive chronotropic, and there is increased conduction velocity of action potential. Answer is that is positive, okay, dromotropic effect. Okay, so how that is happening? So please remember that this increased heart rate, that is positive chronotropic effect, as well as the positive dromotropic effect, that is increase in conduction velocity. These two, okay, is done at the level of nodal tissue. So if you want to understand the effect of these two, how this chronotropic is occurring or dromotropic effect is occurring by sympathetic system, then you have to first understand the nodal tissue action potential, right? So now first you tell me whether you got this action potential of myocardium or not. Okay, so first type action potential is done, right? So all the related things and the associated things we have discussed here. Now we are going to discuss the ionic basis of this slow type action potential, right? Okay, so let's start. So slow type action potential, ionic basis. So I'm drawing this diagram first. X-axis is the time axis and y-axis is the membrane voltage. So this is membrane voltage axis and x-axis is the time axis. I told you already that the membrane voltage will first rise from minus 65 to minus 40 millivolt, and then there will be generation of the phase number 0, and then the phase number 3 again return back to minus 65, and again the phase number 4 or the pre-potential phase will be generated. So this is the way how the action potential is going on in case of nodal tissue. Typically this is seen in case of SA node, as well as this is also seen in case of AB node. Okay, and this is typically of slow type action potential. Fine. Okay, now to understand the ionic basis, again the same thing I am going to do, that is I am drawing one nodal tissue cell just below this. So this is my nodal tissue cell, SA nodal cell, right? Okay, so you start from minus 65 millivolt. So this is minus 65 millivolt. Whenever the membrane voltage is returning to minus 65 millivolt, there will be opening of a very peculiar channel on nodal tissue cell, and that channel is known as H channel or HCN channel. What I'm saying, I'm repeating. So we are starting discussing this phase. What is the name of this phase? Pre-potential phase. Pre-potential is not actually the part of the action potential, it is like a local potential. Pre-potential is also known as pacemaker potential. Pre-potential is also known as the resting membrane potential of nodal tissue. So whenever the membrane voltage is dropping to minus 65 millivolt, there will be opening of a very peculiar channel on nodal tissue, and this channel is a sodium channel. Okay, this channel is a sodium channel. Okay, so the name of this channel is H channel, right? So name of this channel is H channel. What is the H? H stands for hyperpolarization induced channel, but the complete name of this channel is HCN channel. It stands for hyperpolarization induced. Okay, so hyperpolarization is inducing this channel opening. That's why hyperpolarization induced CAMP, cyclic AMP, gated channel, right? So when the membrane voltage is hyperpolarized, then the channel will open up. Now tell me, what is the RMP of the SA node? I told you that it is minus 50 millivolt. What is the RMP of AB node? I told you that is minus 60 millivolt. But ideal answer is a range. But if you have to tell one answer, minus 50, minus 60. So when the membrane voltage is dropping to minus 65 millivolt, it is hyperpolarization in comparison to minus 50 or minus 60, right? So whenever there is this hyperpolarization, this HCN channel or this hyperpolarization induced channel will open up, through which sodium is going to enter within the nodal tissue cell. Although the channel is permeable for potassium also, small amount of potassium will also go out of the cell, but the entry of sodium is more than that of the potassium exit. That's why I can understand that there will be a net gain of positivity inside the cell. This net gain of positivity means the membrane voltage will start rising in upward direction, right? So if I write down this thing, because this is very crucial for MCQ, I will write down for you. So I am writing the ionic basis of pre-potential phase. Pre-potential phase. So number 1, I am writing here that opening of HCN channel through which sodium is entering. But please note down, this sodium entry is nowhere related to the sodium entry in case of myocardium phase 0. That is the voltage gated sodium channel. I told you voltage gated sodium channel is very fast. But if you look at this HCN channel, the sodium entry through the HCN channel is a slow channel. So HCN channel is a slow channel. Sodium entry is a slower variety. That you also have to remember. Okay. So what are the other property I have to remember about this HCN channel? So HCN channel, when it is first time discovered, scientists found out that the channel is very, very peculiar because this H channel is opening in presence of hyperpolarization. Generally, we have seen the voltage gated channel in our body, and voltage gated channel opens in presence of depolarization, not the negative voltage, not the hyperpolarization. That's why when this channel was first time discovered, scientists found out this is very peculiar, and that's why they gave the name that this is a funny channel. That's why the current which flow through this channel is known as funny current. Okay, so the current is very, very funny. So the current which is flowing through this channel is a funny current, right? And the channel, the current is due to which ion? Sodium greater than potassium. And please remember, both of these ions are permeable through this channel, right? But mainly it is sodium permeability. Fine. Then third, you remember that this HCN channel, till date there are 4 different subvariety of HCN channel has been discovered, that is known as HCN1 to HCN4, 4 different subvariety. If I ask you which HCN channel is present in case of nodal tissue HCN channel is not the HCN1. Okay, you must be thinking HCN1, but this is HCN type 4. Although type 2 and type 3 are also discovered, but main HCN channel which is present in nodal tissue of the heart is HCN4. So question is, where the other types of HCN channels are present? They are the neuronal HCN channels. So this HCN1 or 2 or 3, they are present at the level of basal ganglia region, right? They are also present at the level of hippocampus region, also present at the level of hippocampus region. So these are the very few points that you have to remember for HCN channel. HCN channel also open in presence of CAMP. Okay, CAMP, you note down that. Okay, now so we have done the first part. So I'm writing here that the first part of the prepotential is IF. I stands for current, F stands for funny current. Getting my point? F stands for funny. So funny current is generating the first part of the prepotential. Now when the prepotential is rising in upward direction, means whenever the interior of the cell is becoming positive due to the sodium entry, this will open up another voltage gated channel on nodal tissue cell. This voltage gated channel is a calcium channel, but note down here, this calcium channel is not the L-type calcium channel, but here the calcium channel is a T-type calcium channel through which calcium will enter rapidly into the nodal tissue cell. Okay, so T-type calcium channel, T stands for transient type of calcium channel and L stands for long type calcium channel, you all know. So transient calcium channel are rapid in nature, but L-type calcium channel, they are slow in nature, right? So whenever this T-type calcium channel are opening, further calcium is going to enter, it will causes more positivity. More positivity means this prepotential will rise up further and it will reach to minus 40 millivolt. So I'm writing here that the second part of this prepotential is due to calcium current, and this calcium current is due to T-type calcium current. So I'm writing here that the second reason of this prepotential, the second part of the prepotential is due to opening of T-type calcium channel. Okay, T-type calcium channel. This T-type calcium channel is a rapid calcium channel, right? Okay. Now, after the opening of this T-type calcium channel, whenever you are reaching to minus 40 millivolt, what I told about this minus 40 millivolt, okay, could you recall for me? So what I told about this minus 40 millivolt, what is the importance of this? This is the threshold voltage of the nodal tissue. So whenever you are reaching to threshold voltage, what is going to happen? Simultaneously, there will be opening up of huge number of different variety of calcium channel, and that is L-type calcium channel. I will repeat, just hold on. So what is happening? Whenever you are reaching to this threshold voltage means simultaneously there will be opening of large number of calcium channel, but this calcium channel are L-type calcium channel which are slow in nature. Because of the slow in nature, what will happen? The membrane voltage will slowly rise in upward direction up to plus 10 millivolt, and this is nothing but our phase number 0 of nodal tissue action potential. So phase number 0 of nodal tissue action potential, if I ask you what is the ionic basis, okay, so I'm writing here phase number 0 is known as the depolarizing phase of nodal tissue action potential. What is the ionic basis? This is simply due to opening of okay, voltage gated L-type calcium channel, okay, L-type calcium channel through which slow calcium entry is occurring inside the cell, right? This is the ionic basis of phase number 0, or this is the actual action potential, because I told you the pre-potential is not the actual action potential, okay? So the pre-potential is basically a kind of local potential. So pre-potential is done by sodium ion also, it is also done by calcium ion also. But if I ask you what is the ionic basis of nodal tissue action potential, then your answer should focus on this, the depolarizing phase of action potential. Which ion is doing this? Your answer is it is exclusive of calcium ion, no contribution from sodium. Sodium is contributing for pre-potential phase, okay, but pre-potential phase is not the actual part of action potential. It is basically a kind of local potential which is rising the membrane voltage up to threshold voltage. Getting my point? Okay. So now the phase 0 is done. Now after the phase 0, what will happen? There will be opening of potassium channel. So we all know that whenever potassium channel open, potassium goes out of the cell. So now this red color is nothing but the potassium exit from the cell. Okay. So in between. So potassium is going out of this cell. More and more potassium is going out of this cell. So what will happen whenever potassium is going out of this cell? The same thing, the membrane voltage will return back towards this original voltage, that is minus 65 millivolt. So this part is known as the phase number 3. Phase number 3 is the repolarization part. So I'm writing here the ionic basis of phase number 3, okay, that is the repolarization phase. If you compare with the normal myocardium action potential, the ionic basis is absolutely similar. That is, the calcium channel, okay, are closed and potassium channel are still open, right? Because the calcium channel which is generating this phase number 0, that is closed and potassium channel is open. So potassium channel open means obviously the potassium is going out of the cell, more and more potassium exit. So potassium exit means the membrane voltage will return to baseline. So which variety of potassium channel? Again, this delayed rectifier type of potassium channel, that is the KR type of potassium channel, right? So because of this potassium exit, the membrane voltage is again coming back. Now you note down here, okay, whenever the membrane voltage is returning to minus 65 millivolt, right, what will happen to the potassium channel which are already open in phase number 3? Very simple question. When the membrane voltage is returning to minus 65 millivolt, what will happen to this potassium channel which are open in phase number 3? Obviously, they are also going to be closed. So I can understand like this, that whenever the membrane voltage is gradually returning towards this minus 65 millivolt, potassium channel number is also going to be decreased gradually. Potassium channel is also going to be closed. So maximum potassium channel are open here at the peak. Then whenever the membrane voltage is gradually decreasing towards the minus 65 millivolt, potassium channel are also getting closed. So at minus 65 millivolt, I can understand that this potassium channel are already closed, and after the closure of this potassium channel, there is opening up of this HCN channel through which sodium is entering, and whenever the sodium is entering, the membrane voltage will start rising in the upward direction. Getting my point? So closure of this potassium channel is also essential. Why? Because suppose this potassium channel is not closed, potassium channel are still open. So potassium is going out of the cell, and then this HCN channel is open, so sodium is entering. So cell is losing one positive charge, cell is gaining one positive charge. Do you think the membrane voltage will start rising in the upward direction? Answer is no. Membrane voltage cannot rise. Rather, the membrane voltage will be stabilized here like this, right? But we know that in case of nodal tissue, membrane voltage or RM2 will not stabilize. If it is stabilizing, then spontaneous big production capacity or the automaticity property of the nodal tissue will gone, right? So who is helping this prepotential phase to rise in the upward direction? Once again, two things: potassium channel closure has to occur, as well as there has to be opening of the voltage gated sodium channel. That's why we say that although the prepotential is mainly due to opening of this HCN channel, but you require the potassium channel closure. That's why the third reason for this prepotential is written in book like this, that decrease permeability of potassium, is also required for the onset of the prepotential phase. Getting my point? So if I ask you now that what is the ionic basis of prepotential phase, your answer is main is the sodium ion, which is entering through HCN channel. Second part is due to calcium, that is the transient rapid type of calcium. And third is decreased permeability of potassium is also essential. So please remember these three important reasons, because prepotential is very crucial for MCQ purpose, right? So this is all about the ionic basis of nodal tissue action potential. Now we want to find out that if the sympathetic system is stimulated, okay, again the same thing is going to happen, that the beta 1 receptor of this nodal tissue will be stimulated, and beta 1 receptor stimulation means there will be increased generation of the CAMP. We have earlier seen that what is the effect of this CAMP on myocardium cell. Now we want to understand what is the effect of this increased CAMP on nodal tissue cell, right? Okay. So I have stimulated the sympathetic system. Okay, sympathetic system has generated huge amount of CAMP through second messenger system. Now this CAMP is a stimulus for HCN channel. Obviously, because the name of this HCN channel is hyperpolarization induced CAMP gated channel. So whenever the CAMP is high, the HCN channel opening will be faster. So HCN opening will be faster. What do you mean by stimulation of this HCN channel? HCN channel opening will be faster. Whenever the HCN channel opening is faster, what will happen to the slope of the prepotential phase? That is very important. What will happen to the slope of prepotential phase? Look at, so normally suppose this is the nodal tissue action potential spontaneously going on, automaticity is going on, right? Okay, now I have stimulated this sympathetic system. So here the HCN channel is stimulated, due to which this sodium is entering into the nodal tissue cell in a faster rate. So I can easily understand that the slope of this prepotential will start rising at a faster rate. Not only that, okay, not only that. So the slope of the prepotential will be steeper, right? Second, this CAMP is also a stimulus for L-type voltage gated calcium channel, which we have already seen. L-type voltage gated calcium channel, which is responsible for phase 0. That means I can understand that this phase 0, it will also be steeper, right? So both the prepotential phase is becoming steeper, as well as the phase 0 is also becoming steeper. So what is the net result? The net result is second action potential is generating earlier than that of the previous one. That means I can understand that the distance between these two action potential by nodal tissue is lesser. That means what is the effect on heart rate? The heart rate will be faster or heart rate will be rising. So I'm writing here L-type calcium channel stimulation means it will leads to steeper phase 0, okay, steeper phase 0, and ACN channel opening leads to steeper prepotential. The combination of these two is nothing but increase in heart rate, right? So this is the reason how the sympathetic system stimulate the heart rate. So whenever you are trying to increase your heart rate, you have to target the nodal tissue. And if you want to increase the contractility, then you have to target the myocardium fiber. That's why we have seen that the effect of CMP is different in case of myocardium cell and it is different in case of nodal tissue. So at the level of nodal tissue, it is stimulating the ACN channel as well as the phase 0 voltage gated calcium channel. That's why the heart rate will be increased. So if I block this receptor, that is the beta 1, through which the CMP is generated, that is the beta blocker. So all of you know, so if you block this beta 1 receptor, that is the beta blocker, cardioselective beta blocker, that is going to reduce your heart rate, very simple. But not only that, if you give the beta blocker, your heart rate will be obviously reduced. But rather than targeting beta blocker, I can target this HCN channel blocker also. Why? That will be more specific. Getting my point? Although some action is through this L-type calcium channel, but that is negligible. The main effect, the main reason for increased heart rate is occurring through this HCN channel. So why not target that channel? Because if you target the beta 1 channel, then there will be some side effect because beta 1 receptor is present in other places of the body. But HCN channel is located in very few areas in our body, like for CNS and here on heart. So why not target, why not block this beta 1 ACN channel? And we all know that this ACN channel is selectively blocked by a drug that is known as ivabradine. So this ivabradine is a blocker of this ACN channel. Okay, it inhibits the ACN channel by which it decreases the heart rate and it is beneficial for angina or myocardial infarction, but it is typically used for the anginal patient, right? So this is ivabradine, which is blocking the ACN channel and decreasing the heart rate. Getting my point? So this is the effect of your sympathetic stimulation. Now if I ask you what will happen in case of parasympathetic stimulation, just opposite, very simple. So parasympathetic stimulation means you know that the neurotransmitter is acetylcholine and it is going to act on M2 receptor. Whenever you stimulate the M2 receptor, the effect is there will be decreased production of CAMP. So whenever you are decreasing the CAMP, what will happen to the slope of this prepotential? I can easily understand. If I draw here, the prepotential slope will be more slower. It will be more slower. So the second action potential will reach here. So this is the effect of parasympathetic stimulation. So obvious thing is that you can easily understand that the distance between two bit is more. So heart rate will be slower. So I can write down that acetylcholine or parasympathetic stimulation is decreasing the slope of, it decreases the slope of prepotential phase of action, prepotential phase of your nodal tissue potential, right? So it is decreasing the slope of prepotential. Not only that, another thing you have to remember according to Genau, this M2 receptor, okay, it's a G protein coupled receptor. We know the G protein means it is composed of alpha, beta, gamma subunit. 3 subunits are there. It will be discussed in endocrine physiology. So normally the alpha subunit is the regulatory subunit of G protein. Means alpha subunit is going to do the more action of G protein, the action of G protein. But in case of heart, whenever the M2 receptor is stimulated selectively for heart, the beta gamma subunit of G protein is going to open up, okay, is going to stimulate a separate specific potassium channel on nodal tissue. So I'm writing here opening of specific potassium channel, okay, on nodal tissue only, this potassium channel is known as KACH channel. So look at the name. KACH channel means this potassium channel will only open in presence of ACH, and this is typically seen in case of nodal tissue, and this is done by G protein, but not the alpha subunit of G protein, the beta gamma subunit of G protein. This is an exception. Beta gamma subunit is not going to cause much of the action of G protein. Mainly it is done by alpha subunit, but here is the exception. So that's why you have to remember. Now, if you open up extra potassium channel, okay, which is not supposed to open up in normal cases. So look at this diagram. What is going to happen? Because you have to understand this thing. So normally this potassium channel is opening up, and if I ask you what kind of potassium channel these are, I told you this is delayed rectifier potassium channel. Whenever your acetylcholine is stimulating this nodal tissue, you are opening up another potassium channel which is known as KACH type of potassium channel. So more potassium will go out of the cell. More potassium means the membrane voltage will not stop at minus 65 millivolt. It will go for more negative direction. That means there will be more hyperpolarization of the nodal tissue cell membrane. More hyperpolarization of nodal tissue cell membrane. More hyperpolarization means again your heart rate will be decreased. Why? If you look at this diagram, you will be easily understanding that whenever the membrane voltage is going for more and more hyperpolarization like this, so this is due to KACH. So what will happen? It will take long time to return to the threshold voltage and long time to generate a second action potential. So that way, this KACH is causing hyperpolarization of the nodal tissue cell, and decreased CMP is inhibiting this HCN channel. The combined effect of this parasympathetic is that there will be decrease in heart rate by parasympathetic stimulation. Getting my point? I hope now this is clear about the molecular mechanism of how parasympathetic is decreasing the heart rate by reducing the slope and by causing hyperpolarization, and how sympathetic system is increasing the heart rate, and previously we have discussed how sympathetic system is causing increased force of contraction. So this is all about your ionic basis of action potential and their applied aspect. But before closing this session, I'll show you one diagram, okay, from GNOME, okay, because you know this kind of diagram you may get in image based question. So look at this, very simple, we have already discussed this, right? So what is this? This is nothing but action potential. Which type of action potential? Fast type or slow type? This is a kind of fast type action potential, means myocardium action potential, Purkinje fiber action potential. So phase number 0, okay, that is the sodium entry. Now if you look at the bottom of this diagram, you are getting certain graphical representation where it is written INA. That is the sodium current. I stands for current, sodium current. But look at the direction. Look at the direction. This negative direction does not mean sodium is negative charge. This negative direction means this is entry of sodium into the cell. So whenever this direction is in downward direction, that means entry of ion, and whenever the direction is in outward direction, this is exit of ion. So we have already seen this thing. So just look at that. First, the phase number 0 is due to the sodium entry. So that is depicted here. Sodium is entering in the cell. Then the calcium entry is occurring during the phase number 2. So this is calcium entry. And potassium exit start from the phase number 1 and it continue up to phase number 3. That's why we are finding out that there is a exit of potassium throughout this action potential duration from phase number 1 to phase number 3, right? And I told you that phase number 1 means, okay, what potassium channel? KTO type of potassium channel. Phase number 2, I told you that KTO type of channel is there, as well as there is delayed rectifier type of potassium channel. And phase number 3, these channels will be present, that is delayed rectifier channels will be present, as well as there is another variety of potassium channel, that is KIR. I stands for inward rectifier potassium channel will also open up, inward rectifier channel. So if I ask you what is the ionic basis of this phase number 3, your answer is potassium exit, which is exiting through the delayed rectifier type of channel, that is KR or DR, and whenever it is going close towards the resting membrane voltage, more and more IR type of channel will open up. What is this? IR stands for inward rectifier channel, right? And at the end, I hope you remember the name of different phases. Phase 0 is the depolarization, phase 1 is the initial rapid repolarization, phase 2 is plateau, and phase 3 is simple repolarization, and phase number 4 is nothing but the resting membrane potential or baseline. So this is all about your action potential on heart.